Welcome to Roadmap to Residency, Evidence-Based Applications. Hello everyone. So in this video, we will be discussing some of the questions from the pharmacokinetics part, because only discussing the theory is not enough. We have to also go through some of the questions, solve some questions, some calculation sort of questions to truly understand pharmacokinetics. Now, drugs that are administered intravenously are rapidly absorbed, subject to first-pass metabolism, 100% bioavailable, rapidly excreted by the kidneys, rapidly metabolized by the liver. I hope that you all are able to answer this question. So, by definition, IV administration does not involve absorption because there is no movement from the site of administration into the blood. The IV route avoids first pass metabolism, which is common with orally administered drugs. First pass greatly reduces the bioavailability of many drugs, and drugs given IV have 100% bioavailability. That is F equals to 1, since the entire dose is in the systemic circulation. No conclusions can be drawn about renal or hepatic elimination of a drug, knowing only that it was administered IV. So the answer is C. We have another question with us. So drugs that are highly bound to albumin are effectively uh, bound to albumin, effectively cross the blood-brain barrier, are easily filtered at the glomerulus, have a large volume of distribution, often contain quaternary nitrogens, can undergo competition with other drugs for albumin binding sites. So since most drugs are lipid soluble, they will need a carrier in the blood, most commonly albumin. Drugs bound to albumin do not get filtered at the glomerulus or cross the blood-brain barrier. Binding to plasma proteins keeps drugs in the plasma, resulting in a lower volume of distribution. Highly protein-bound drugs are good candidates for interactions with other drugs that are also highly bound. Example, warfarin plus sulfonamides. So most drugs can injury to the cells by passive diffusion with zero-order kinetics, passive diffusion with first-order kinetics, active transport with zero-order kinetics, active transport with first-order kinetics, or passive diffusion through membrane pores. So the permeation of most drugs through cellular membranes is by the process of passive diffusion, a non-saturable process that follows first-order kinetics. Concentration gradient and lipid solubility are important determinants for the rate of diffusion. Only a few drugs are important determinants for the rate of diffusion. Only a few drugs are substrates for active transport processes such as active tubular excretion or penetrate membranes via aqueous pores. Now, which of the following is phase 2 drug metabolism reaction associated with a genetic polymorphism? Acetylation, glucuronidation, oxidation, reduction, or glutathione conjugation? So phase 2 drug reaction involves the transfer of chemical groupings, example, acetyl, glucuronide, glutathione, to drugs or their metabolites via conjugation reactions involving transferase enzymes. Acetylation reactions are associated with genetic polymorphism, which is slow acetylator. These individuals are slow to metabolize drugs via acetylation and are particularly susceptible to drug-induced lupus when taking hydrolyzine, procainamide, or isoniazid. Both oxidation and reduction are phase 1 metabolism reaction. A woman is taking oral contraceptives. Which of the following drugs is unlikely to reduce the effectiveness of the oral contraceptives? Carbamazepine, phenytoin, ketoconazole, phenobarbital, or rifampin? So answer is C. Azole antifungals are inhibitors of cytochrome P450 enzymes, especially CYP3A4, the most abundant isozyme formed in the human liver. 3A4 enzyme metabolizes a wide range of drugs. Ketoconazole would actually raise the plasma level of oral contraceptives, increasing the risk of side effects, but it would not reduce their effectiveness. All of the drugs listed here are P450 inducers. As such, they will tend to lower the plasma levels and decrease the effectiveness of oral contraceptives. Here we have a 500 mg dose of a drug, has therapeutic efficacy for 6 hours. If the half-life of the drug is 8 hours, how long would a 1 gram dose be effective? 8 hours, 12 hours, 14 hours, 16 hours, or 24 hours? So the fact that the drug has therapeutic efficacy for 6 hours has no direct relationship to its half-life. It simply means that the drug is above its minimal effective concentration for 6 hours. Doubling the dose to 1 gram means that the drug level will be above the minimum for a longer period. Now, because the elimination half-life is 8 hours, 500 mg of drug will remain in the body 8 hours after a dose of 1 gram, which means that after we have administered 1 gram, now after 8 hours, 500 mg of drug will remain, and this 500 mg will remain for 6 hours. Now, we know that 8 plus 6 equals to 14 hours, so the answer is 14. Answer C. Normally, gentamicin has a volume of distribution of 20 liter and concentration of 80 ml per minute, clearance of 80 ml per minute. If gentamicin was administered to a patient with 50% renal function, what parameter will differ from normal? Then we have the volume of distribution and clearance of the drug. And the question is asking about the parameter. Now, loading dose will be higher, maintenance dose will be lower, T half will be shorter, VD will be 35 liter, or clearance would be 700 ml per minute. So the patient has renal dysfunction, which reduces the renal clearance. This would necessitate a lower maintenance dose for medication, such as gentamicin. The maintenance dose equation is as follows. Factors in renal clearance, while the loading dose equation does not. The T half of gentamicin will be increased in this patient due to the decrease in clearance, but the VD will be unaffected. Pharmacokinetic characteristics of propranolol include volume of distribution 300 liter per 70 kg, clearance of 700 ml per minute, and oral bioavailability of F equals to 0.25. What is the dose needed to achieve a plasma level equivalent to steady state level of 20 microgram per liter? 4 mg, 8 mg, 12 mg, 24 mg, or 48 mg? So answer is D. So loading dose equals to volume of distribution into Cp by bioavailability. So the answer we get is 24 mg. Now with IV infusion, a drug reaches 50% of its final steady state in 6 hours. The elimination half-life of the drug must be approximately 2 hours, 6 hours, 12 hours, 24 hours, or 30 hours. So the rules for time to steady state are that it takes 4 to 5 T half to reach clinical steady state. It also takes 1 T half to get halfway to steady state. Since the drug got 50% of the way to steady state in 6 hours, its T half must be 6 hours. Very important concept. Now, at 6 hours after IV administration of bolus dose, the plasma level of a drug is 5 mg per liter. If the VD, volume of distribution, is 10 liter and elimination half-life is 3 hours, what was the dose administered? 100 mg, 150 mg, 180 mg, 200 mg, or 540 mg? So at 6 hours after IV injection, which corresponds to 2 half-lives of the drug, the plasma level is 5 mg. Extrapolating back to 0 time, that is doubling plasma level for each half-life, results in an initial plasma level at 0 time. So 5 mg into 2 equals to 20. Now dose equals to concentration, or you can say concentration into volume distribution, that is 200 mg. Thank you for watching. Keep studying.